Our topic today is keep your brain happy, action steps to prevent Alzheimer's and dementia. Important to know that dementia is an umbrella term for severe decline in mental ability that can be caused by various underlying causes that damage brain cells, whereas Alzheimer's is a specific diagnosis. It's the most common type of dementia, and specifically, it's caused by proteins in the brain that form amyloid plaques and things called neurofibrillary tangles, and it actually causes the brain cells to shrink and die over time. The reason we're going to highlight Alzheimer's, especially in this presentation, is because that women are 2 times as likely to get Alzheimer's as men. 2/3 of all patients with Alzheimer's are women, and women over the age of 65 are 2 times as likely to get Alzheimer's than breast cancer. We want to reframe how we think about the disease of Alzheimer's. So the old way of thinking about it was that this amyloid plaque, which is again that protein that we see build up in the brain with Alzheimer's, that was really the target for therapies. There's been a lot of medications, billions of dollars studying how do we decrease the amount of amyloid in the brain, and does that then reduce the risk or reduce the symptoms of Alzheimer's? And those studies have failed to show any improvement. And what we're seeing now is maybe amyloid is more the effect rather than the cause, meaning we're seeing Alzheimer's now as a whole network of dysfunction of metabolism, inflammation, hormones, toxins, infections, nutrients, lifestyle, all kinds of different things influence risk. You can see that there's a lot of ways that we can actually reduce our risk of Alzheimer's. Let's take a moment to talk about what is normal memory loss versus dementia-related memory loss. Importantly, age-related memory decline is things like misplacing your keys, feeling like problem-solving skills are slower, but you can still complete those problems, relatively stable or very gradual declines in your overall abilities, and your day-to-day life is not seriously impacted. Whereas dementia is very frequent forgetfulness, especially in familiar places. Being unfamiliar with a location, you're driving home from your grocery store you've been going to for 20 years and you don't know how to get home. A serious decline in problem-solving abilities, sudden severe changes in mood, sharp decline in abilities that worsen over time, and day-to-day life is significantly impacted. Let's talk now about the actual brain changes with menopause itself. So when we lose our estrogen at the time of menopause, we see that we actually have a temporary shrinkage in some of the structural areas in the brain. There's an overall reduced energy metabolism, and that's what you can see in that photo at the bottom. That bright color is energy uptake. You can see that it actually is significantly lower after menopause. And there's altered connectivity. We see reduced gray and white matter in the temporal lobe and hippocampus, and those are primary memory centers in our brain. Also increase in amyloid deposits, and then a compensatory rise in estrogen receptor density. What that means is your brain is actually screaming for estrogen at the time of menopause. It's putting out more and more receptors to try to capture any estrogen that may be in the body since it's dropped to pretty low levels. We see brain fog, memory issues, mood fluctuations, and heightened anxiety. Midlife is an independent risk factor for dementia risk, specifically when you go into menopause early. Maybe they went through surgical menopause because of a cancer treatment, or they had chemotherapy, or sometimes it can just be from genetic causes that they lose their egg supply and estrogen at a very young age. But midlife is a risk factor where we see that menopause itself can increase multiple risk factors for developing dementia. Okay, how do we actually think about ourselves and what is our risk? First, we want to think about your family history. If any type of Alzheimer's or neurodegenerative diseases run in the family, especially on the maternal side. Menopause timing, again, that's what I was just saying. If your menopause was earlier, and I should specify it's if it's early and then that person did not receive treatment. So their hormones were not replaced back. They just lost their hormones at a young age and then stayed at those low levels. Sleep quality, depression and anxiety, physical activity and diet, alcohol intake. Then we think of our cardiometabolic targets. Whatever protects the heart protects the brain. These are things that are very much in our control and ways that we can really lower our risks. First being blood pressure. The lower, the better, the more protective. The A1C, which is a great measure of our blood sugars and insulin resistance, want that to be in low normal ranges, which is less than 5.7. Triglycerides as well. HDL, that's the quote unquote healthy cholesterol, but that one is very responsive to activities. LDL, it says it's individualized. There's no exact target, but in general for LDL, really the lower is the better. And then waist circumference, less than 35 inches. That's really thinking about that visceral fat, which is the fat that can be around the organs and the abdominal cavity. Recommended labs, there's a comprehensive metabolic panel, a blood count, which is a CBC, again, doing all of those blood sugar testing, a lipid panel, which is your cholesterol panel, thyroid testing, vitamin testing, HSCRP, which is one of your inflammatory markers, homocysteine levels, which is also an inflammatory marker, and then thinking about more individualized testing with cardiac screening and sleep studies. There's also a specific lab called ApoE that some of you may have heard about, and ApoE is actually a genetic marker. People who have one copy of the E4 gene are at an increased risk, and people who have two copies are at a significantly increased risk. At this time, guidelines recommend against routine screening. And Dr. Kelly and I have a nuanced approach to this. This type of testing is available and we can order it. Sometimes it's fairly distressing to be able to get this testing because at this time, there is no treatment for E4 carriers other than the knowledge that you're at a much higher risk of dementia. And importantly, all of the preventative mechanisms and strategies we're talking about would be the same. People with E4, they just might want to stick to them in a little bit more of a rigid way. Let's talk about what is the number one lifestyle intervention for dementia and Alzheimer's risk reduction is exercise. Exercise has the absolute strongest evidence for any lifestyle intervention that we have available. The main targets are that 150 to 300 minutes per week of movement. So that's 2.5 to 5 total hours of movement. I tell people that total hours can be spread out throughout your week. Maybe you go on a 20-minute walk on your lunch break. Maybe you do a 90-minute hike on the weekend, and then 2 to 3 times a week of resistance and strength training, and thinking about balance and mobility training as well. Exercise, why it's so powerful is that it increases BDNF. And I'm going to have a slide on that next. I'll explain that more. But it's a critical brain protein that maintains neuroplasticity. It improves insulin sensitivity and enhances cerebral blood flow. So we'll do just a little spotlight on what it is. So it's brain-derived neurotropic factor, and it's a crucial protein as a fertilizer for our brain, supporting growth. Like I mentioned, the synaptic plasticity, which is essential for learning, memory, higher level thinking, and low levels are linked to depression, stress, and cognitive decline. So this is the reason that exercise is absolutely the best thing we can do because it really keeps those BDNF levels high and keeps them there lifelong if we remain active lifelong. Thinking about other things that influence BDNF is again a Mediterranean diet, which we'll talk more about, omega-3 fatty acids, exercise, like I mentioned, is there. And these are all things that increase BDNF, decrease inflammation, and increase insulin sensitivity, which is what we want, opposite of insulin resistance. And then things that decrease BDNF are things like a high amount of simple or processed carbohydrates, a sedentary lifestyle, and that kind of more classic sort of Western diet. This is one of the most important things we can do. It's called the MIND diet. And they've actually done studies to say, hey, if we put people with early signs of cognitive decline on this diet, how do they respond? And it's been one of the few interventions that's shown a pretty massive improvement in their symptoms. So it's prioritizing leafy greens every single day, vegetables 5 servings per day, and the size of your fist is 1 serving. Olive oil as your primary fat, nuts, seeds, and legumes on your plate as much as possible. Fatty fish 2 to 3 times per week, berries twice a week, and whole food sources of carbohydrates. And then really thinking about limiting ultra processed foods and sugar and refined carbs. And we'll go into this too much in depth, but basically really prioritizing vegetables and low glycemic foods, thinking about moderate protein intake, and then also setting a goal of around 12 hours of overnight fasting and trying to stop eating around 3 hours before bedtime. That those can be lifestyle changes that will keep you in a low insulin state while you sleep, which can further contribute to brain health in addition to healthy nutrition. Of course, sleep is very critical for brain health. Goal is 7 to 8 hours per night. And so really putting a huge focus on actually treating insomnia if it's something that you suffer with. And we know that insomnia increases a ton with perimenopause and menopause, and it can be assisted with hormone therapy. You can also use more sleep-specific medications or supplements that can help. And thinking about managing vasomotor symptoms, which are your hot flashes and night sweats, because not only do they disrupt sleep, but we also see that it can have a greater impact on the brain, where if you have vasomotor symptoms throughout the night, you have a decrease in your memory consolidation and an increase in various inflammatory markers we've been talking about. And then thinking about morning light exposure, which is getting actual real light from the sun into your eyeballs 30 to 60 minutes upon waking. And this is really critical for the clearance of amyloid, that protein we keep talking about, and memory consolidation. Next is stress management. Chronic stress is when your stress levels just remain high day after day versus acute stress, which is actually quite helpful for us. Acute stress is things like exercise. Chronic stress is more of that day-to-day stress where we never really get that full recovery. It's linked to shrinking of the hippocampus, which is again one of your main memory centers, increased inflammation, and poor sleep. Things like time in nature, mindfulness, meditation, breath work, yoga, tai chi, and removing toxins in your life, but also toxic things like toxic relationships, a toxic work setting, setting boundaries, working with healers, things like that. And then there's the toxins, where more of like the actual things that could be in our environment. So reducing alcohol, avoiding smoking, avoiding ultra processed foods, and avoiding the environmental toxins like mold and heavy metals. Things like adding water purifiers and just being mindful of the environment that you live in, that if any of those are present, that you're doing your best to minimize your exposure to those things. And then cognitive engagement, we think of learning new skills, complex hobbies, language, music, and dance. I think this one is a really cool one because we think of cognitive engagement, I think, as like doing crossword puzzles, which is great. Nothing wrong with those. But some of the best data is actually when we do creative types of movement, where you're combining exercise and movement with a new novel skill like dance or any kind of creative expression. Those are highly stimulating for the brain, as well as regular social interaction. All of these things build up cognitive reserve. So it's not just doing your crossword puzzle, but actually thinking about things that have a little bit more of a creative element, and especially if it's a creative movement and social element. So now let's talk about actual hormone therapy. So is it good or bad for our brains? At this time, hormone therapy is not recommended by any major medical society for dementia prevention. Our data is limited and mixed, and the decision to use hormone therapy for your brain health is part of a shared decision making. First, we know that the presence of estrogen has a number of incredibly important functions in our brain. They support synaptic function and neuron survival. And synapses are what connect our neurons together. It enhances cerebral blood flow. It reduces amyloid accumulation, that protein, as well as tau. Tau is another protein associated with Alzheimer's disease. It improves metabolic resistance of our neurons. What we know is that estrogen not only functions as a neuromodulator, but also a neuroprotective hormone, not just a reproductive hormone. So we have estrogen receptors all over our brain, and especially in our memory and learning centers, where it's really important for synaptic plasticity, as well as neurogenesis. Neurogenesis is the growth of new neurons and neuron connections. So then we think of the loss of estrogen. Lisa Mosconi is one of the main people really increasing our knowledge in this space. She's very incredible. She has a book called The Menopause Brain as well, if you're interested in her work. When you lose estrogen at the time of menopause, it decreases the glucose metabolism in the brain, decreases synaptic density and plasticity. It increases neuroinflammation and oxidative stress. It decreases your mitochondrial efficiency, which is the energy producers in our body, and altered neurotransmitter regulations, altered serotonin, dopamine, and acetylcholine, and then disrupted sleep and vasomotor symptoms that can further impair cognition. We see that the loss of estrogen around menopause may contribute to an increased risk of Alzheimer's disease, especially in susceptible women, from these various pathways that are pretty pro-inflammatory. How about progesterone? So the data on progesterone is more limited. We have even less on the progesterone part than we do on estrogen. This is the body identical progesterone. It's called micronized progesterone. It has a sedative effect because it acts on your GABA metabolites, which are part of your sleep pathway. It improves sleep latency and quality. It reduces the amount of nighttime awakenings, and it can reduce anxiety as well. So since sleep quality is so important for cognition and dementia risk, we think progesterone likely has more kind of indirect brain benefits through sleep improvement. But the data we have available on body identical progesterone is overall very reassuring, although it is a space that is evolving. We have less data on it. Let's talk about the actual clinical trials, because some of you may have heard some people tell you, possibly even doctors, who say hormone therapy increases dementia risk and we should not be using it. Where does that data come from and why are they saying that? It is coming from the WHI. This is the largest study that's ever been done on women's health. It was done in 2002. And it showed an increased risk of dementia in women who took conjugated equine estrogens and medroxyprogesterone. And I do think it's important for us to actually write out the words of exactly what women were taking in that study, because it's too simple when people just say estrogen and progesterone. But medroxyprogesterone is a totally different compound than our body identical progesterone. And what they saw is that women who took that medroxyprogesterone had 22 additional cases per 10,000 patients. That equated to a 0.22% increased risk in the study. And importantly, in the women who were on the conjugated equine estrogen only, they showed no change. So they didn't necessarily see a benefit, but they did not see an increased risk. And this was especially true for the women who were younger. The 22 additional cases were women in their 70s who were starting hormone therapy. So that was women aged 70 to 79. And that's where we saw those 22 additional cases. When you hear about people saying there's an increased risk, they're specifically talking about the data that we have that was using medroxyprogesterone specifically as the progesterone in older women aged 70 to 79. Next, we have the Alzheimer's and dementia study that was done in 2021. And this showed a significantly decreased risk of dementia and neurodegenerative diseases when you're using the body identical estrogen and progesterone. It's important to know that this was not a randomized controlled clinical trial like the other study was. This was a retrospective trial, which basically means these researchers analyzed thousands and thousands of people in claims data, saying, hey, let's look at all of the people who died of dementia and Alzheimer's and other types of neurodegenerative diseases. How many of them were on hormone therapy? And specifically looking at the body identical hormone therapy because the data we have available looks the most reassuring for that. And what they saw was a pretty significantly decreased risk of not just Alzheimer's, but all types of neurodegenerative diseases, which includes things like Parkinson's, other causes of dementia. So that was 46 per 1,000 fewer cases of neurodegenerative diseases, which equates to about a 4.6% reduced risk. This is from Louise Newsome. She's a doctor in the UK who's fabulous, and she is a huge part of growing research in women's health on hormone therapy and menopause. Her research group looked at all the different meta-analyses, and they basically compiled this infographic that you can see. On average, there's 46 cases of dementia per 1,000 women above the age of 65, and that's just kind of baseline risk. There was 14.5 fewer cases in women who were started on estrogen within 10 years of menopause, and then 10 fewer cases on women who were started on estrogen and progesterone within 10 years of menopause. You can see the little blurb at the bottom. She basically writes that the clinical studies that are available are limited, and specifically, they think that difference in the estrogen versus estrogen and progesterone is because a lot of the studies do include the synthetic types of progesterone. So, what's the summary then? Hormones, especially estradiol, which is your estrogen, improves neuroplasticity and metabolic regulation. We have the best evidence for starting hormone therapy early, around the age of 50, and there's less clear benefit when it's started at a later age. The only study that showed there was that increased risk or harm was when it was started at a late age, meaning in the 70s, and the women were given synthetic forms. The discussion to start hormone therapy is really individualized, and it's based on what you and your doctor feel is best. Dr. Kelly and I feel pretty strongly that this is going to be an emerging area where once we have the data available, likely we are going to see that we really have been misguiding women and telling them to avoid hormone therapy because it's bad for their brain. There are also supplements that can be really helpful for brain health. The omega-3 fatty acids have absolutely the best data behind them for increasing lipid density in our neurons. Also, they're anti-inflammatory. They've been shown to slow cognitive decline in early stages, and they've been actually shown in studies to reduce the dementia risk. That brand right there is my favorite. They're Nordic Naturals. They are third-party tested, so they don't have mercury in their products, and they also have sustainable fishing practices. And then there's vitamin D. The complex can lower homocysteine levels, which is one of those inflammatory markers, or if you're vegetarian, especially vegan. Magnesium, especially the glycinate or threonate. There is emerging studies on these. You can see the evidence. The stars are decreasing a little, slightly lower evidence. Will be really helpful for sleep quality, stress reduction, and then possibly encouraging synaptic growth. I know a lot of people hear about creatine and the brain. This evidence is emerging but promising. 3 stars for quality of evidence, but in that 3 to 5 grams per day dose, it's been shown to improve energy metabolism, cognitive resilience under stress, and muscle preservation, which we know if you preserve your muscles, you can stay active for longer, and how good that is for your brain. Secondary supplements, I won't talk about these too much, but curcumin, CoQ10, ALA, polyphenols, and probiotics. These are all largely the supplements on here are mostly anti-inflammatory, which is why they're thought to help the brain, but the data is a little more limited. Let's talk about the conclusions and take-home points. The biggest thing to know is that we really want to put a huge focus on the things that are in our control to treat. Things like hypertension, which is high blood pressure, prediabetes and diabetes or high blood sugars, dyslipidemia, which means high cholesterol, obesity, sleep apnea, and depression. Whatever protects your heart protects your brain. If you are someone who has any of these conditions, we want to work with you so that we can optimize all of those levels and get them into ranges where we can really optimize your overall health, which will optimize your brain health. and your highest return on investment interventions. Exercise is absolutely at the top of your list. 2.5 to 5 hours of total movement and your strength training, blood pressure and metabolic control, prioritizing sleep, that Mediterranean mind diet, and social and cognitive engagement. And we don't want to rely on supplements. They are meant to supplement a healthy lifestyle, and prioritizing exercise and nutrition as the very top things. Then how do we actually apply this clinically? So first is to do an annual risk assessment starting in midlife. Those different risk factors we talked about, gathering any person's cognitive concerns they may have, and filtering if those sound like more concerning cognitive concerns or the more sort of expected times that can happen with hormonal shifts. Doing labs, especially every 6 to 12 months, especially for those cardiometabolic and inflammatory markers. Lifestyle coaching, which again is thinking about the nutrition component and the activity component, and really considering hormone therapy when appropriate. Again, I know we are biased, but biased, I think, in an appropriate way where we're really looking at the data, looking at what we have available to us. And when we analyze that data, it does seem to be that hormone therapy is pretty darn protective. So it's something I would recommend fairly strongly to most people, especially if they have a family history of dementia or they're just worried about their brain and wanting to optimize brain health. And then again, monitoring your cognition and symptoms. So if any symptoms do emerge, that you seek early evaluation, because once again, we have a long runway for dementia. If you were to develop any symptoms that are a little more concerning for true cognitive decline, for us to do a much more in-depth analysis on that person, and also that all these things we've talked about, that you might just have to ramp them up to a much stronger degree so that we can protect your brain. Thank you, everyone, for joining us.